I want to spend this block going over the actual mechanics of emesis and walk you through the different phases of this process. It's basically broken down into three phases, or can be. One would be the pre-ejection phase, and that is also known as the prodrome phase. If something is prodromal, what that really means is when you have an experience that something else is about to happen. So typically, emesis or vomiting is associated with nausea. So if you're nauseated, that would be considered a prodrome phase, and it was something leading up to actual ejection of gastric contents. It's a medical term. You could also apply it in other contexts as well. If somebody's having migraines and before they have the migraine, they have this sense that a migraine is coming on, we would call that a prodrome. So pre-ejection phase or prodrome, obviously nausea. It is not the case that nausea always precedes vomiting, but for the vast majority of the time it does. It is theoretically possible for someone to vomit without nausea, but that's rarely the case. Usually nausea is involved. We have and we'll talk about this in coming lectures, we have a vomit center in the brainstem itself, but the experience of nausea is not just a brainstem function. The experience of nausea also includes higher brain centers. So when you're in that nauseated state, part of giving you that sensation is going to be structures of the brain that are above the brainstem itself. And so some of the areas involved would be the insular cortex. We have the cingulate gyrus. And there are other areas of the brain as well, so we're just going to say etc. here. Also, the basal nuclei, I forgot to say that. Basal nuclei, we know these are involved. And then etc. These are not the only ones, but these are the ones that are seem to be the most involved in that. So for drugs that are involved in trying to help nausea out, scientists basically are focusing in on some of these, particularly the insular cortex, trying to alter its activity to reduce the subjective experience of nausea. So nausea has to be distinguished neurologically from the act of emesis or vomiting. Several other things goes on during this prodrome phase. In addition to nausea, we just go a different color here, the GI, smooth muscles, begins to relax. So you have actually a reduction of GI gut motility. And then what's going to happen is that the lower esophagus begins to relax, and then that cardiac sphincter or the lower esophageal sphincter will also begin to relax. Then what you can have is a retrograde peristalsis of the proximal portion of the small intestine, and we've been talking about that as the duodenum. So why would that be the case? Well, what's happening is you know that your contents of your stomach is very acidic, so you have very low pH. When the gastric juices, when the gastric content of the stomach goes into the duodenum through the pyloric valve, the small bowel, starting with the duodenum, it is not designed to handle that level of acidity that you find in the gastric contents of the stomach. So the acid that goes through the pyloric valve into the duodenum has to be neutralized. And so one of the things that the pancreas does is that it is going to push bicarbonate into the duodenum. And bicarbonate, if we think of bicarbonate, think of Arm & Hammer baking soda. It's very effective in reducing or neutralizing acids. So and again, the pancreas does many things, but one of the things it does, it is going to be pushing bicarbonate in the duodenum, and its job is to neutralize all that acid coming down from the stomach. Well, if you have retrograde peristalsis, where you're actually having the contents in the duodenum reflux through the pyloric valve back into the stomach, then you're basically pushing a high content of bicarbonate into the stomach, and that bicarbonate begins to reduce the acid nature of the gastric contents. That is something you actually want, because if you're in the ejection phase and propelling the gastric contents from the stomach, it's still going to be acidic, but it won't be as acidic as it would be if you didn't have that reflux from the duodenum back into the stomach. So that also begins to happen. So contents of the duodenum will make its way back into the stomach, and also you'll recall that bile is also going to follow that as well, and again it has kind of a green-yellow look to it. Another thing that's going to happen is you're going to have longitudinal contraction of the esophageal muscles, which actually will pull the stomach towards the thoracic cage. So if you can imagine, again, we have an esophagus. Well, I'll just go ahead and move this over here. And let's just say esophagus, and then we'll have our stomach here, something like that. So you have two types of arrangements of the esophagus. And remember, the lower part of the esophagus is going to be all smooth muscle. Then the middle part of the esophagus is a mixture of smooth muscle and skeletal muscle. And then the upper third of the esophagus is all skeletal muscle. But in the more distal ends of the esophagus, what you have is you're going to have circular smooth muscles. Okay, little rings there. And, of course, those are going to be contracting in normal situations, propelling food down towards the stomach. But then you also have longitudinal arranged muscles as well. And what I'm telling you is during this phase, those longitudinal muscles can begin to contract, and they will just gently pull the stomach up towards the thoracic cage here. Another thing that happens in this pre-ejection phase is going to be talism. And the talism is actually a fancy word for hypersalivation. So you're going to be making a lot of saliva. And so that is going to be driven by the cranial nerve 7, which is your facial nerve, and cranial nerve 9, which is your glossopharyngeal nerve. Recall that the two major areas that produce saliva is going to be your parotid glands, and that's going to be on the side of your faces, and that's going to be driven by the glossopharyngeal nerve. And then the other is going to be the salivary glands that are in the floor of your mouth below your tongue, and those are going to be innervated by your facial nerve. Now, you will recall that saliva production, that is going to be a parasympathetic event. So I'll go ahead and write this out for you. Parasympathetic. And we associate the parasympathetic part of the autonomic nervous system as what gets stimulated right after a very fine meal. So when your parasympathetic system is stimulated, that is going to be enhancing GI motility, it's going to be enhancing saliva production, etc. So that's on the parasympathetic side of things. So part of the parasympathetics that has to do with saliva production is actually stimulated. And the reason for that is thought, as you're increasing your saliva production, what happens to all that saliva? You begin to swallow it. So the additional saliva, thinking to lubricate the esophagus, and also the saliva, which is not acidic, it's more neutral. If you're making more saliva and it's going to the stomach, again, expanding the content of the stomach, and that dilutes the acid in the stomach as well. So you're in this nausea stage, and again, that could last for a pretty good length of time. But right before you transition from the nausea stage to the next stage, which is going to be retching or dry heaving, what's going to happen right before you enter the retching phase, you're going to have a strong contraction of the diaphragm, and this is going to be complements of your phrenic nerves, your right one and your left one. And remember, that is controlled by the neurons in your cervical cord at levels C3, C4, C5, and then that is in turn controlled by your respiratory centers in your brainstem, your medulla, and your pons area. But they're going to cause a strong contraction of the diaphragm in coordination of contraction of the upper esophageal sphincter. And you'll recall the upper esophageal sphincter is skeletal muscle, and the major muscle of that sphincter is going to be that the cricopharyngeus muscle. I mean, it just kind of hooks around the esophagus there. And remember, it is always tight until the appropriate time. But this one here is going to tighten up even more because what it's doing is as the diaphragm is contracting, so now you're trying to inhale, you don't want air to go into the esophagus, so the contraction of that upper esophageal sphincter is going to actually prevent insufflation, which is basically a taking in of air in the esophagus, because it's a pretty strong contraction when you're leading into the retching stage by the diaphragm. So speaking of such, let's move on to the retching phase. And in street language, it's called the dry heaves. So what you're going to have, again, you're going to have inhalation, and again, the inhalation is being coordinated by the respiratory centers in the brainstem. What will also happen is your glottis is going to close. Now, if you continue to contract your diaphragm and you close off your glottis, that means you cannot draw air into your lungs. Well, what that does as the diaphragm continues to contract is it really drops the pressure in your thoracic cage, creating a significant negative pressure in your thoracic cavity. The negative pressure, as you are trying to further inhale, and again, this is not something you're thinking about, this is all reflex, but as the nervous stimulation, the pharynx nerves are causing that diaphragm to contract even more against a closed glottis, and again, you're not consciously closing your glottis, it's part of a brainstem reflex to close that glottis and then contract that diaphragm. That is, again, going to increase the negative pressure in the thoracic cage. It is thought that that negative pressure is going to be helping or aiding moving the gastric contents into the esophagus, because the esophagus is now surrounded by that negative pressure, which lowers the resistance of gastric contents from stomach going into the esophagus. It kind of aids that. And again, during this process, your glottis is going to close, which again, your vocal folds are going to slam shut, and this is mediated by cranial nerve 10, which is, of course, your vagus nerve. At the same time, during this first retch, or this first dry heave, I'm going to have, again, contraction of the diaphragm, but then I'm also going to be having a contraction of the abdominal muscles, and this little cycle is going to be in about 1 second oscillations. And so this is where I want to go back and contrast this with what we talked about earlier in normal respiration. In normal respiration, particularly if it is heavy respiration when I am expiring after doing some exercising, I want the abdominal muscles to contract and I'm wanting the diaphragm to relax. That then allows you to squeeze the lungs from the bottom, building up that pressure in the lungs so that you can create a greater flow rate out of the lungs. But if we're talking about this dry heave situation, we have a little bit of a different situation here. So I'm just going to kind of scheme it out for you to make my point. And that would be that if I were to, I'm just going to make this box here, it's going to be my thoracic cage, and there's my diaphragm there. And then the bottom box is going to be my abdomen. So it's going to be my thoracic cage here, my abdominal cavity here. And of course you have the diaphragm here. So I just kind of put that there, and then it, diaphragm. Okay, so think about this. What is happening? Now I'm going to have simultaneous contraction of the diaphragm and the abdominal muscles. Again, that's not what happens when you're doing a forced exhalation. So if I am sending a signal to where now I am contracting the diaphragm, so it's going down, and I am also contracting my abdominal muscles, and you can look and see where the forces are going. So with the contraction of the diaphragm with the glottis closed, that is going to drop the pressure in the thoracic cage here, the thoracic cavity, but also what it's doing, it is greatly increasing the pressure in the abdominal cavity because I am squeezing from the sides and I am pushing down, generating pressure in that area. And the whole point here is that I'm wanting to create a pumping action, literally squeezing the stomach from the outside, shoving, pushing, driving the boluses of gastric contents into the esophagus. All of this is happening at the same time. So the simultaneous contraction of the diaphragm and the abdominal muscles, again, is coordinated through the respiratory centers. Of course, ultimately this is being coordinated through the vomit centers or the emesis centers that we're going to talk about in a coming lecture. So this is very, very interesting in terms of how this compares with a forced expiration. So again, simultaneous contraction of diaphragm and the abdomen. Now again, while this is going on, which is why this is dry heaves, I'm having a contraction of that cricopharyngeus muscle, not allowing anything to be ejected, which is again why we call it dry heaves. So the physics on that is pretty interesting, I think. So I'm going to have retrograde movements. Again, the retrograde movements, again, it's going to be the gastric contents going into the esophagus. And I have a summation here again, just to kind of recap what happens. These are all cotemporal. They're all happening at the same time. So I'm having abdominal muscle contraction. I'm having contraction of the diaphragm. I'm having the contraction of the antrum of the stomach. Remember, that's that lower area of the stomach. And again, I'm literally trying to push things from the lower area to the upper area of the stomach. I'm going to have the constriction of the pyloric valve. So now the pyloric valve was relaxed when I was in the prodrome phase, when I was in the nausea phase, allowing gastric reflux from the duodenum into the lower stomach area. But now, as I'm squeezing the stomach, I don't want the contents of the stomach to be driven back into the duodenum, so I've got to really clamp down on that pyloric valve, creating the forces such that the only place the gastric contents can go is back up into the esophagus. At the same time, I'm going to have that relaxed lower esophageal sphincter, and I'm going to have a relaxation of the fundus. And I'm going to have the constriction of that upper esophageal sphincter. And this is actually going to prevent the ejection, so hence the dry heave. So you're going to cycle through that about 1 time a second for a few cycles. The strong contraction of the diaphragm and the abdominal muscles is also, again, mediated by the respiratory centers and the medulla and the pons. And again, I've already talked about, again, contrasting this with normal forced expiration, so I'll not rehash that. So why are we doing all this? What's the purpose of the retching? Well, one of the things that is thought to be happening here is that the retching actually is going to help mix the reflux gastric contents. Remember, I'm having the gastric contents from the duodenum. It's sitting in the bottom of the stomach. I've got saliva coming down, trying to dilute the acid. It is thought that part of the function of the retching is to kind of churn up and mix the contents in the stomach such that I have an overall reduction of the degree of acidity in the gastric juice. It's still quite acidic, but not as much as it could be. And the other possible function of the retching is it's going ahead and moving the gastric contents into the esophagus. Again, remember, I got that upper esophageal sphincter is really clamping down, not allowing anything to leave. So this is kind of a mixing type of event that goes on. So then you transition from retching on to the final stage, which is we call the ejection phase. And this is actually going to propel the contents of the stomach out the mouth. So these would be even more powerful contractions of the diaphragm and the abdominal muscles. And again, not all emesis events are the same. Sometimes it's more powerful, sometimes it's less powerful. And again, I'll also tell you that the degree of retrograde peristalsis can also vary. Sometimes you have a lot of retrograde peristalsis. Sometimes you have less retrograde peristalsis. It really depends upon what is causing the nausea and the vomiting to begin with. Typically, I would expect if the cause of the emesis is something GI related in terms of an irritant or a pathogen or some chemical in the gut, I would expect a more extensive retrograde peristalsis. If you're throwing up because you have motion sickness, probably less retrograde peristalsis. So again, not all emesis events are the same. Again, it depends upon what's causing it. But again, have more contractions of the abdominal and the diaphragm, except this time it's not oscillating, one per second and then going through, oscillating, relaxing, contracting, relaxing, contracting. It is a more sustained contraction, of course, because the point here is then to propel the contents out of the stomach, out of the mouth. So what also happens, unlike during the retching, where you have a relatively negative pressure in the thoracic cage, during the ejection phase, the pressure in the thoracic cage actually is going positive. It is thought that the case there is because I'm actually taking lots of content, expanding the esophagus, and taking all the content from the stomach and going through the thoracic. So it's thought that that may move it from a negative to a positive pressure as it's propelled through the esophagus. So what I wanted to do here was just kind of lay out to you all the things that are happening. Again, everything is about coordination. All the things that are happening during the actual ejection phase. So again, what I'm going to have is simultaneous contraction of the diaphragm and abdominal muscles. I'm going to have that pyloric valve. It's still going to be clamped down because I want the gastric contents to go one way, and that's out the mouth. The antrum is going to remain contracted for obvious reasons. My lower esophageal sphincter, or the cardia, sphincter in the cardia area, and the fundus of the stomach, that's going to remain lax. Now, this is what separates this from the retching, because now in this situation here, I'm actually going to have a relaxation of the upper esophageal sphincter. And again, the upper esophageal sphincter made of skeletal muscles, made of several muscles, the lower pharynx and the upper esophagus, but the main muscle involved there is going to be, again, the cracopharyngeus muscle. So that's going to relax. Another thing that's kind of interesting is that, remember when we talked about the swallow reflex, where you have taking the hyoid bone and it goes up and forward, and then you're having your larynx, that thyroid cartilage, again, going up and forward. During the swallowing reflex, all of that apparatus is moving up and forward, literally pulling open the esophagus. So you're going to have a relaxed upper esophageal sphincter, but then the larynx and the hyoid bone move anteriorly and upward. Well, the same thing happens during the ejection phase. So what you're going to have is you're going to have the hyoid bone and the larynx going to move up and anterior and literally will pull open the esophagus. Again, it's going to be a coordination of several of these hyoid muscles, and cranial nerve 5, cranial nerve 7, and then 3 spinal nerves are going to be involved in this coordinated movement. So not only does the upper esophageal sphincter relax, I'm actually going to be opening that thing up by moving the larynx and the hyoid bone. Reflexively, your mouth will open, and that's going to be driven by your trigeminal nerve. The mandibular branch of your trigeminal nerve will open your mouth up reflexively. Your tongue will protrude, and of course that's going to be a hypoglossal function, cranial nerve 12. Your glottis will close, again, for obvious reasons. You want that glottis closed. Again, it's going to be taking the 2 vocal folds. You're going to adduct them, seal them off, because you don't want to aspirate the gastric content, so you're trying to protect the larynx, protect the lungs by sealing that off, not allowing any type of aspiration to go, or any type of gastric contents to go down into your larynx and into your lungs. That would be bad. And then also your soft palate is going to elevate, and that's going to be a function of cranial nerve 5 and cranial nerve 7. We talked about during the swallowing. You want to elevate that soft palate so that the contents that are, in this case, coming out of the stomach, you don't end up vomiting through your nose, so that soft palate will elevate. All of these things happen at the same time. So you can imagine there's a lot of interesting neurology behind this in terms of coordinating this beautiful neurological dance of all of these muscles, resulting, of course, in injecting the contents of the stomach. A few other things happen. During emesis, you're going to have a stimulation of your sympathetic nervous system. So typically during a vomit event, you're going to be sweating. And again, sweating is a sympathetic event. You're going to have tachycardia, your heart is going to race, and you're actually going to have constriction of the capillary beds in your skin. So you're going to be losing some red color in your skin. It will also be, it will be losing its, the warmth of the blood flow, etc. So interestingly enough, what you have during the ejection phase is going to be a mixture of both parasympathetic and sympathetics happening at the same time. So my parasympathetic is going to be increasing that saliva production. But at the same time, I'm going to have the sympathetic event, which is going to again be causing racing of heart, sweating, and again constriction of capillary beds in the skin. You sometimes will hear the phrase projectile vomiting, and that's just a descriptor. Basically, it is what you think it is. It's just projectile vomiting is when you have the contents of the stomach are coming out with such force that it's actually, spewing out a fair distance. Again, that's just adjectives that describe the violence of the vomit or the emesis event itself. Last thing that I want to talk about, just a brief moment, is to distinguish emesis or vomiting from regurgitation. Regurgitation is not vomiting. When babies regurgitate all the time. Regurgitation is when food is taken down, it's in the esophagus, it doesn't quite make it to the stomach yet, and then the esophagus is pushing the content back out the mouth. So whatever is regurgitated never made it to the stomach, so therefore you don't have an acid problem there, of course. So that's a distinction there. And as you know, repeated vomiting is not good for the mucosa in the esophagus, because the mucosa in the esophagus, unlike the stomach, is not designed to have all that acid around it. And so it irritates the esophagus. There are a lot of bad things that happen when you have repeated vomiting. One is exposing the mucosa of the esophagus. That's never good. The other, if you're vomiting, you're certainly disturbing your electrolyte balance. You're losing a lot of electrolytes out of your gastric contents. Also, repeated vomiting, one of the major problems with that is going to be you're throwing off your acid-base balance in your body, so you are ejecting or losing a lot of acid, which could easily move you into metabolic alkalosis, and that has its own challenges as your body tries to respond to that. And then also dehydration. You're losing a lot of fluid. And so, again, a lot of bad things happen if we're talking about repeated vomiting, which is why it is important to have that under control. Okay, so this is just kind of, vomiting from a physics perspective. So again, to recap, basically all of this is a very effective pumping action to take whatever's in the stomach and propel it out the mouth to get rid of whatever is offending the system in terms of the stomach. So again, you're basically literally just squeezing the stomach through all of these coordinated things, and then you have ejection. Okay, so that's a wrap for that. So what we're going to do next time is we're going to start moving into now the neurology of it to understand the neurobiology basis of how all this is happening. So until then, I'll see you later.